My name is John Phair. I'm a vascular surgeon. I work at Mount Sinai in Manhattan and Mount Sinai in Queens. The landscape of acute limb ischemia has really changed drastically over the past 20 years. In the past, the only other options were open surgery, and then it advanced to lytics. However, there's a lot of downside to them. And for subacute clot and chronic clot, they don't work well. After that, you have suction thrombectomy, which you're limited by the size of the vessels. Sometimes they don't maneuver well, and then you have to switch out for different size devices for whether you're dealing with the iliacs, SFA popliteal, or the tibial vessels. The first case, this 63-year-old patient came in with acute on chronic worsening of a lower extremity wound. I decided to give Artix a try. Some of these other suction devices are reliant on suction technology, which is going to suck the clot in, but you may have clot adherent to the walls. And they force you to kind of push their catheter into the walls of the artery to really clean it off. Whereas this felt intuitive. You have a blood clot sitting in a vessel, and the idea of just pulling it outside the body makes sense. You know, it's something that you could feel. It's adaptive to your movements. The more skill you have as an interventionalist in any way, working with wires and catheters, the more you're going to feel comfortable with it, and the more you'll be able to do with this device. You always have a wire across the lesion. In other technologies, you have to lose the wire in order to increase your luminal gain to have this aspirational quality. But this, you're able to maintain a complete 100% removal of thrombus, whether it's subacute or acute, without losing your wire access. For my first time using this, I felt safe because of the inward-facing features of the struts. It was able to collect all the thrombus within 4 or 5 passes. Then the funnel that ceases forward blood flow and allowed us to work freely with no concern for distal embolization during the procedure. That embolic material could have potentially been really dangerous. The patient embolized down to the leg. You're looking at potential amputation. So we were able to clear all those small little particles out. The mechanical element itself was able to work inside the sheath with rapid and quick exchanges. Each pass took less than 30 seconds. And when we were all said and done, it was only 40 minutes of device time for that entire thrombectomy procedure. You know, I've worked with a lot of different products before, and this was one of the most expeditious cases that I've done with one of the cleanest results I've ever had. Another case I had was a 67-year-old man who came in with rest pain. We did a diagnostic angiogram on him, and in addition to chronic tibial disease, we noted either acute or subacute thrombus in the profunda artery. Now, we were unsure whether the Artix device would track well inside the vessel, but the length of the profunda vessel looked suitable for deployment of the funnel, and we were able to get the 7 French device up and over the aortic bifurcation, planted in the profunda, and do 3 passes. The funnel was able to maintain its integrity throughout the case. It didn't pull back with each pass. We were able to remove the clot. We didn't see any associated spasm of the vessel afterwards. We didn't see any intimal damage from passing the mechanical element multiple times. We were able to maintain the position of the sheath throughout the entire case. All the profunda branches remained patent afterwards. At the end of the case, the patient had improvement of his symptoms, and in addition, I did some tibial work that was able to restore blood flow to the foot, so he had a palpable pulse at the end. Inari, they asked me questions about clinical utility of the device, what could be changed, what could be better. I think that they listen. I think they have an intuitive understanding of the disease process, and they're not trying to just retread old ground. They're actually trying to put something innovative forward, something that's different. They're perceptive, they're knowledgeable, and they really do care about outcomes. This is the Inari Artix device. The deployment is very simple, and it stays in place without any backward and forward motion inside the vessel. It's a pin and pull type of technology that's unsheathing it. And so this is the mechanical element. And so most of the clot, as you're pulling back, will come through here. However, there's inward-facing struts midway up the mechanical element that allows to capture clot even if there's stenotic areas. So what we'll notice when you take this device out, not only is there clot in this area over here, but in the deeper part of the mechanical element, there will be clot there. A major pitfall in some of these other technologies can be distal embolization. What this device does is able to combine this capture with a mechanical element and the thrombectomy portion of the filter itself, as well as the filter quality, because the mechanical element is essentially a net that's capturing the clot that's extending past it. So once you deploy it past your lesion and pull it back, you're protecting yourself from embolization. Again, and then once you get all the clot out, recaptured is fairly simple. You just very carefully pull this back, and it completely recaptures and is ready to go again. Between passes, it's a very quick and efficient way of cleaning this mechanical element, recapturing it and putting it back in the body. This goes over an 0-4 wire, but it's very flexible, very adaptive, so this had no issues going over a very tortuous aortic bifurcation. It was able to get around kind of 3 J loops of this without any kickback or any issues like that. The versatility of the technology is what's really groundbreaking. This is really a cutting-edge new way of thinking about things with this technology that responds to the vessel size. It fits adaptively into the vessel you put it in. I think it really changes the game because it allows for fast procedure times, no lytics, and ability to remove chronic, subacute, and acute clot. I was also able to work in every single vessel. I worked in the tibial vessels, I worked in the distal popliteal artery, and then my second case I was able to work in the profunda without risk of further embolizing down to distal branches, which could have been catastrophic had I used other devices. And so in this situation I was able to really choose one device that was able to fit all these different parameters. I think a lot of physicians are creatures of habit. They like to stick to things that they know, and if you're not willing to change, as new technologies come, you're going to be forgotten. You're going to offer worse outcomes. Seeing is believing, and doing is believing. And once you start doing it, my results were fantastic for both cases.